Hi, everyone. Thank you for attending the third of the lectures for Thanksgiving weekend. This is on transport operations, all of the different types of transport vehicles, what there's basic general procedures, how a call goes from call dispatch to scene management and transport until you're back at service. And what it, in my opinion, and what in the National Registry's opinion, makes an excellent EMT. So there, as I mentioned in the previous video, I think it's important to get into the habit of doing the techniques ritualistically, doing these things so that every time you make the bed, you clean it off perfectly. Every time you fold it in, it's nice and it's set up and there's not hanging wires and oxygen tubing that's going to be bundled up and stuck in things, and that everything works according to plan. Because the truth is, if you've ever been in the military or worked in a paramilitary or an organization, when you're dealing with emergencies, things inevitably go wrong. There's always some other factor that you have to manage when you're dealing with these calls. So we as EMTs should do our best to minimize any of those potential situations, any of those snafus that can occur. And then if something should occur to us, we can at least go back and fix that without having to worry about everything else. So I'm going to get started and go through. This is a short one. This is a really short one. And I just wanted to make sure that everybody got this before the video. Who knows? I may not put many of these on the final. However, these will be covered in National Registry, and I'm going to have all of these lectures up on Zoom and on Canvas and on YouTube so that you can continue to watch these until you take your National Registry exam. Okay. Sorry, guys. Been chaos over here at the Allen House. So, in any case, introduction. Let's talk about what we're going to be discussing here. We're going to talk about what the logistics are from someone making a call to 911 to the dispatcher, sending out info, setting out people's information to us, any additional things that should be passed along, what the dispatcher can tell the patient to do. And then from there, how do we kind of manage just that first part of patient assessment, the scene size up? That's what really plays into EMS operations. And then when we transport to the hospital, how does that go? So we'll talk about the different phases of the call, as I'm mentioning here. Knowing your crew, your equipment, your apparatus's capabilities. You should learn how to prepare for success, or at least not make too many mistakes off the bat. And types of transport vehicles. So let's refer back to this throughout the rest of the lecture. What do great EMTs do? What do we do? Well, we prepare for the calls, and that means before we even get into service, we check all of our gear. And this occurs if I have a 5 a.m. shift. I'm there at 4:30 checking all of my gear so that I roll wheels at 5 a.m. That's the way this shift call goes. If you've been to the fire stations during the your ride-alongs, you know that they're there prior to 8 a.m., which is when shift begins, checking their gear, getting a review, giving a history on what the crew before them went on, what should be checked on the engine, on the equipment, if they're missing something, if something broke. All of those things are relevant, and they need to be played and put into practice prior to the first hour, the first minute you go into service. So we prepare for calls by getting ourselves and our equipment and our apparatus ready prior to the beginning of shift. We review the dispatch information that we're getting. We make sure that we are thinking in advance what that information may imply. We're safely responding to calls, and that means even with lights and sirens, you're driving carefully. Certainly, if you're going against traffic or through reds, that is a situation where we're still liable. Perform a good scene size up and be prepared to return to the scene size up if needed. This means you go in and you check scene safety. And then you begin taking that call. Well, about halfway through that call, you may realize the scene has now become unsafe, or you didn't catch something. You have to step back and go and fix that issue. Step away if you can until the scene is safe, or bring the patients with you if the scene suddenly becomes unsafe. But this is a reanalysis throughout the call, and be ready to do that. You may not even decide to do a helicopter until, you know, 20 minutes in because the ambulance that gets a flat tire. So you call for air ambulance. Those are harkening back to your scene size up stuff. Perform prompt patient assessment and emergency cares, and always on scene manage unstable airway, breathing, and circulatory problems. You need, if someone is compromised, you have to manage airway, breathing, and circulation before you leave that call. That means if they have a sucking chest wound, you put your gloved hand, you put an occlusive dressing, they are going to die if you don't do that immediately. That means if someone is in cardiac arrest, you begin CPR. They are going to die if you don't do that from the scene to the hospital. If you're not managing airway, breathing, and circulation, it doesn't matter how quickly you respond. If you don't do anything on scene and they tank, well, that's the end of that. Also, if you are first on scene, you're updating any responding units to what's going on, additional call issues, additional logistical things. Number of patients is changing, or in the best possible situation, the call is not as serious as it came out as on the dispatch. So there's been a few calls where we say we're going on cardiac arrest, and you get there and the person's just sleeping. That's a nice reassuring update. And now we run our call, we take care of our patients, we bring them to the hospital, and we complete the post-run activities like patient handover report. We clean our ambulance, we prepare our equipment for the next call, and throughout this whole procedure, we are well aware of the location and the neighborhoods we work. That means knowing the roads, bringing the correct equipment, knowing the apparatus's capabilities, and knowing when to use what on these calls. And again, you're going to learn this stuff as you work. So be prepared to screw it up a few times. It's fine. Don't kill somebody in the scheme in the course of that, but for sure, be aware that you're going to do this imperfectly for a while. So before we prepare, we go through our gear. This is the drug bag. This is the paramedics ALS bag. It's basically one of those Pelican cases that has all of the medication that we would be giving, as well as some of the syringes, sharp shuttles, some of the maybe an IV bag in there, but it's all of the ALS circulatory stuff with some of the medications for airway and breathing. Be prepared to respond promptly, most direct, and know the right path to get there. That means so you're ready to go when shift begins. And you're also knowing which way to get to that call. In the old days, we had map books, and we'd go to the map page and try and figure out from where we were the navigation path to where we needed to be with the fastest possible route. And that is it taking into consideration traffic, time of day, weather patterns, all of those things factor into it. Nowadays, it's a lot easier to just type it in Waze. Nevertheless, you should be doing that. And it doesn't hurt to have a backup and look on the map book yourself and learn how to do that manually should your Waze malfunction or you lose power or something like that. Make sure you have the proper equipment when you're going in there. That often means grabbing more than you probably will use on the call, but bringing it all in there just in case. So we may have a sprained ankle. We still bring in the monitor every time, and we get blood pressures and pulses and O2 sats from it as well. But if something else occurs, we have that there to manage. So bring the gear in. You need to stock your gear after every call, and you've been doing a pretty good job of this throughout the semester. When we run a scenario, whatever was used during that scenario, you grab it from the inventory lockers and put it all in there the way it was before, so that the next crew showing up has it. Sometimes that can't be done because the equipment broke. That has to be passed along and that has to be fixed either by the incoming crew or the officers or the supply portion of the department that could get you good working order stuff. Remember, this is required by Department of Transportation regulations. If you are going out, you are out of contract. And that is a major legal issue. So make sure you have all the gear. We also not only check it every day, but we go through it monthly and we take a look at our expiration dates. We look at the gear that we have. We just double check that even if it hasn't been used, the normal wear and tear of it being in the bag maybe didn't open up one of the sides of the sterile packet, or we haven't looked at, oh yeah, the IV fluid has has expired, and it's a 5-year shelf life on that, but you don't check it that often. You go, oh look, this is out. So checking inventory daily, but also monthly. And then we go through all of these things, including you should pull out your ambulance, have the person who's driving turn on the engine, turn the siren lights on, turn the turn signals, hazards, side snake lights, all of the different lights, and have your partner say, yep, that works. Yep, that works. Yep, that works. Yep, that works. No, that's not. Let's go tell deployment. Is that something you want us to, let's say the hazards don't work. All of our lights and sirens do, but our actual ambulance hazards don't work. Is that something that you are comfortable with us going out and using when they know that ambulance doesn't have that ability? So, something like that. Is whatever's broken or not working properly, is that does that constitute a replacement of that ambulance or that equipment? And make sure you report all of this up the chain of command. Let everyone know, dispatch, your officer, your captain, your supervisor. Okay, so the phases of an EMS call. So we've checked all of our gear. It's starting off at 8 a.m. We've gotten there early. We went through our equipment. We went through our engine. We got a handover report from the crew that's leaving. Say everything's tip top, ready to roll. You go and fill out your paperwork, daily inventory sheets with your name and signature so that there's always probable handling of the equipment. That's going to always be the case. And then as we're working, we get a call. Okay, we're putting our stuff, just putting it away, and they say, we got a call. You're responding to a call. Well, what should we do when we're going to these calls? Get in the ambulance, acknowledge that the call has gone out and you've received it and that you are en route. Travel quickly and safely to the call, considering traffic patterns and the time of day. And that means you're not speeding. In the ambulance, we go the speed limit, but we have, if code 3 lights and sirens are going, we have the option of, once clearing an intersection and it's our red light, we can inch through it should it be safe enough to do so. That also goes for going against traffic. If you are going against traffic, make sure that you have assessed it and it's not going to be an over hazard to do that. There are blind turns. There's massive traffic in the opposite direction. It has to make sense. Our goal is to get there a little bit quicker, a little bit safer, a little bit more, a little bit quicker, if not safely, then at least efficiently. So you're always putting everything a little higher at risk if you're running reds and you're going the opposite direction down roads. And so the reason we do it is because we believe the patient's life is in danger. There is a compromise of airway, breathing, and circulation. And our rush to that call, going with lights and sirens, again called code 3, is to get there and assess for ourselves, does this patient have a compromise of airway, breathing, and circulation? And if so, we package them quick, we load and go to the hospital, and we are going code 3 to the hospital. Always wear your seatbelts. Keep your equipment belted down, secured. Um, it will fly everywhere. Use the warning devices according to the state laws. That means using the sirens the correct way as you go through. You'll learn this, but as you take the ambulance through an intersection, you go from the long whale to the wigwag, the anytime you go through an arterial, you're supposed to do the high low, the quick up and down, quick one. That's by Department of Transportation standards. Don't go faster than it's safe and drive defensively. It's usually not our fault that an ambulance gets into an accident. That is usually some oblivious public who's not knowing what to do or isn't paying attention. Nevertheless, if it is you going against a red and you get hit, it is your fault because you were supposed to clear that area before going through. So make sure you're doing it safely and always think patient first, think scene safety first, and think treatment first. I was going to say, most of the time when we go on these calls, most of the time when we go on the calls, we get their code 3. We assess if their airway, breathing, and or circulation is compromised, then we load and go and we head out code 3. Probably 8 times out of 10, they are stable. They are managing their illness or injury very well. So we go code 3 and we drive back code 2. Should something happen, then we can upgrade to code 3 and get going. But that's typically how that goes. We go code 3 to the call, and then we go code 2 to the code 2 to the hospital.